Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. All right, it's another edition of the Healthcare Unfiltered Express. Balaj, we're launching this new product of Healthcare Unfiltered Express. We're very happy to have you talking a little bit about lung cancer and trying just to understand a little bit about these practice-changing things that folks need to know rapidly, efficiently, and effectively. So let's start a little bit with early-stage non-small cell lung cancer. What are you seeing there, especially after the recent ASCO meeting?
Absolutely. So excited to be here with you, Chad. Yeah. ASCO 24, we renamed ASCO Lung because there were just so many big presentations. Prior to ASCO 25, it wasn't obvious that this is going to be a great year, but it actually ended up being a significant year in terms of major updates. And one of them involved early stage lung cancer. Now we have the 5-year updates with an overall survival benefit of Checkmate 816. Patrick Ford presented the data. And it's really just a transformational study of three little cycles of neoadjuvant chemoimmunotherapy, leading to a very significant benefit when it comes to event-free survival. Now we know overall survival. 10% of extra patients seem to be cured by just those 3 cycles of neoadjuvant treatment. So it's very nice to see kind of the long-term impact of that information. Patrick Ford's data, it's a good Ford model to work with. It's also a fairly cheap one if you think about it, with just 3 cycles of neoadjuvant treatment. And if you look at the outcomes, now we're learning more and more that patients who enjoy a pathological complete remission, which is about a quarter of the patients or so, these patients have an amazing outcome without any further treatment. 95%, 5-year overall survival, they're just astounding. So it gives us now a biomarker as to patients where maybe further treatment might just not be, that helpful. So I think, studies focusing on that patient population, looking at, maybe no treatment as a reasonable option, and practitioners following that as well, is the right approach. Now that also
Are there,
leaves.
are
Yeah.
there patients you would give adjuvant versus neoadjuvant today, or everybody should get neoadjuvant if they qualify for chemo?
Well, I think, patients where you think the patient would benefit for any type of perioperative treatment and the patient is a surgical candidate. So we're talking about node-positive patients, large primary tumors. Anybody with a T3, maybe even a large T2, certainly node-positive. The neoadjuvant approach is going to, give you the definitive long-term benefit. Adjuvant treatment, chemotherapy, of course, offers benefit, but very modest. And the adjuvant immunotherapy studies really haven't showed, that much tremendous benefit yet. So neoadjuvant is the way to go for the large majority. The big question is, after surgery, should patients receive further immunotherapy or not? Now we know that patients who have enjoyed a PAT-CR, the benefit probably is very, very limited for additional immune treatment. So maybe surveillance is an appropriate approach. For patients who have not enjoyed a PAT-CR, certainly their outcomes is not as good, and those patients tend to be maybe the PD-L1 low patients, etc. Maybe no ctDNA response. Could adjuvant immunotherapy help them? Maybe. We actually do not know. There's not been randomized comparisons, and maybe they need more than adjuvant immunotherapy. So the best approach for them is to think about clinical trials to try to answer, what further treatment they could benefit from. Outside of clinical trials, at least discussing the option of further adjuvant immunotherapy is reasonable based on the results of Keynote 671, Checkmate 770, et cetera, et cetera.
This is very helpful. Let's shift gears to small cell lung cancer. You were telling me lots of excitement of small cell lung cancer. We just talked about non-small cell. What's happening in small cell that you'd like folks to hear and listen and know about in the next couple of minutes?
For the last 4 decades, we've been saying small cell, big problem. This year, small cell, big changes. This ASCO was a huge ASCO for small cell lung cancer. Number one, we saw the results of the IMforte trial, looking at maintenance lurbinectedin in addition to maintenance immunotherapy for patients with extensive stage small cell lung cancer after completion of 4 rounds of induction treatment. Maintenance therapy outside of immunotherapy has not shown benefits for small cell lung cancer for ages, but now suddenly lurbinectedin demonstrated a significant benefit, not just delaying progression, but an actual overall survival benefit, with a fairly astounding hazard ratio of, I think, 0.47, something in that ballpark. And with the agent being readily available and fairly reasonable, practical to use in clinic, it's a very easy shift, I think, for us to make in terms of moving that up into this maintenance setting. But then even bigger news comes from the Delphi 304 trial, randomizing now patients between tarlatamab and standard of care second line chemotherapy, with tarlatamab just blowing second line chemotherapy out of the water. Tarlatamab is a BiTE molecule, taking a big bite now out of small cell lung cancer, bispecific T cell engager. We all need to learn about cytokine release syndrome, ICANS, how to manage it. But it seems like we're shifting towards maybe models whereby outpatient administration will be appropriate for at least some patients. So that's good news. But the even bigger news is a hazard ratio of 0.6 in this particular study in terms of overall survival benefit. That's massive. That's massive. So that completely confirms now tarlatamab as the right agent upon progression, on frontline treatment and potentially maintenance lurbinectedin and immunotherapy in patients with small cell lung cancer. But it also, makes us think that this will be, kind of a set of musical chairs in the coming years. If there's this much benefit in the second line setting, how about in the maintenance context? How about earlier on? How about limited stage small cell lung cancer? So you can just see kind of the expansion of the horizons for tarlatamab, which we had to rename starlatamab after ASCO 25 as it became the star of the show. And if one BiTE molecule is so successful, maybe that's an opening for a larger spectrum of similar agents, that can lead to significant and potentially durable responses for maybe not just small cell lung cancer, but way beyond as well.
So this agent is being looked for now in earlier, like in the limited stage disease.
Very correct. So the company, and this is not the only BiTE molecule targeting DLL3, which I should have highlighted before. So this company and many other companies are very quickly shifting into those studies. The maintenance trial actually just completed accrual just a couple of days ago. I know that for a fact because by random luck, I think I accrued the last patient on that trial last Thursday. So that's something I'm kind of proud of right now.
Well, Dr. Balazs Halmos, thank you so much. This is so helpful to really look at two things that are not only practice informing, but like you said, practice changing. Thank you so much for coming on Healthcare Unfiltered Express.
Thank you so much for having me.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.